Welcome to part 2. This section is going to focus on assessing/recognizing cues, the first part of the nursing process, and in my opinion, the most important step. I will be using both the nursing process terms and clinical judgment model terms for each section to make it easier for you to understand the flow. Just know that the clinical judgment model terms are the terms we will use on exams and on your care plans. I have the picture of the clinical judgment model again, and if you notice, assessing and recognizing cues are in red. They are the same step. I like to think that they made it red because red is a power color, an attention grabber, and because everything we do as nurses starts with assessing our patient. If we do not do our assessments, we cannot recognize the cues that we gathered on our assessment. Our assessment gives us everything we need to know about our patient. A fun fact about the human body is it'll tell us 24 hours in advance that it's going to die. It's up to us to assess and find those things in the body telling us and recognizing those cues so we can intervene and stop the body from dying. When we do our assessments, the primary source of information is our patient. We do our nursing health history, our general survey, our vital signs, our physical assessment, our behavior observation. We do a chart review to find the labs and diagnostics, and all of this is based on our patient. We do all of this. Why? Because we need as much information we can about our patient to figure out what's going on so we can figure out what to do for them. When we do our assessments, we're not just doing the act of assessing. Yes, we're gathering the information, our data, but we also analyze the data, validate the data to see if the changes are expected or anticipated, and we communicate that data to the appropriate members of the healthcare team. All of this data we collect reflects how the person's health is functioning and how their illness or disease is affecting them. We analyze this data to create our plan of care, so we need to be sure that we are assessing correctly. We also need to take our data from the assessment to distinguish what is normal and abnormal, both for textbook cases and patient-specific. Once we get into disease processes, you will notice that no person is exactly the same. You'll be analyzing the data to recognizing what is relevant and what is irrelevant for that person. The act of recognizing is what is relevant and what is irrelevant is the basis of clinical judgment term recognizing cues. You are recognizing the cues that the body is giving you to see what is relevant and irrelevant. What matters most? There are several different types of nursing assessments we do. It doesn't matter what kind you are doing, we are following the same rules every time. 1, our assessments are purposeful, meaning we don't go into the patient's room to do an assessment if an assessment isn't warranted. We have a purpose for why we are doing them, and that is to gather data that we need to create our plan of care or evaluate our interventions. Secondly, we prioritize our assessments. The first thing we do is to assess our patients. We do not give medications without assessing, and we do not do any intervention without assessing. Think back to BLS. What was the first thing you did before you started doing anything? You assessed the scene safety, then you assessed if the patient was breathing and had a pulse. We always assess first. Third, our assessments are systematic. We all develop our own way to assess our patient. The more we follow that way, the less we will forget and less likely we are to get off track from what we need to do. Fourth, our assessments are factual and accurate. We never make up assessment findings. If we can't figure out what we're seeing or hearing, we ask another nurse for help. And fifth, we record our findings in a standard manner. Most facilities will teach you how they want you to document your findings and follow their procedures. When it comes to the type of assessments we do, there are several, like I said. We do our initial or comprehensive or head-to-toe assessment, and that's where we're getting all of our information about the patient from head to toe. We might do a focused assessment if we only need to reevaluate a body system, or if we need to give medications that require assessments. We can do a quick priority or emergency assessment where we don't have time to do the full head to toe assessment because the patient isn't stable. These very fast assessments are looking at emergent issues. We don't care about their skin, we don't care about their cap refill, we care if they have an airway, we care if they're breathing, and we care if they have circulation. And lastly, we might do follow-up assessments to evaluate our interventions. So when it comes to the types of data we get from our assessments, we have subjective and objective data. Subjective data is data that we get communicated to from our source, specifically our patient. Subjective data would be that the patient's describing their symptoms or rating their pain or telling us how something occurred. It is straight from their mouth. It's direct from the person. Because they are saying it, we are going to document it in quotations. If the patient is telling us the information, the patient is the primary source. This is their own experience with what they are telling us. If someone else tells us the information, maybe the patient can't speak, isn't awake, a witness event that was told to us by someone else, that would be a secondary source. It was not the patient telling us their personal experiences. And when we get subjective data, we need to make sure that we are considering the reliability of the source of the information. Okay? Could the patient be lying to us? Maybe they're in the emergency department and a police officer is in their room and they don't want to get in trouble. Could the family member, who is our secondary source, be trying to cover up something? We also need to consider our own personal biases. As much as we want to say we aren't biased, we are. We all have past experiences that shape our thoughts. Personally, my mom was addicted to prescription pain medications. For a long time, I had bias against people who claimed they were in pain but were laughing and playing on their phones. I assumed they were lying, but that is not my decision to make. That was my bias. The second type of data we have is objective data. This is the data that we have gathered and documented during our physical assessment. It is observable, it is measurable, it can be seen, heard, felt by someone other than the person who's experiencing it. Objective data are things like vital signs, measurements, diagnostic tests, labs, head-to-toe assessment findings. And because this is observed data, objective data could be us personally witnessing interactions or behaviors. So after we've collected all of our subjective and objective data, we need to look at all of the data to see what is relevant and irrelevant. You will be using all of your knowledge about disease processes to do this. One important thing to note is sometimes normal data is relevant. You could have a patient having all of the symptoms of an infection, but their vital signs are normal and they don't have a fever. That information is important and should be relayed to the provider. So when you are going through your data and looking for those cues, don't always discount normal data. Also, you need to look at the data to see what's normal for that patient. Some disease processes have very specific symptoms, but not every patient has all the symptoms. And some patients may have symptoms that are not common for a specific disease. So knowing what is normal for your patient is very important. Like I said, assessment is the most important part of the nursing process. And as such, we will discuss assessment findings as we go through the different diseases this semester. If you're nervous about the nursing process after this part, I suggest you really get your assessment techniques memorized and know what to look for in the normals and what the normals sound like. If you know the normal assessment findings, you can recognize abnormal findings easier. This is the end of part 2. Move on to part 3.